Am I visible to everyone?
Yes, sir. Yeah. Please go ahead, Dr. Gunjar.
Yes. So myself, Dr. Gunjar Jain, I'm Assistant Professor, Department of Orthopedics, AIMS Bhubaneswar. So I would be presenting regarding osteoporosis management and fracture lesion service. So osteoporosis, it is disease doesn't have any symptom. It's a silent killer, and osteoporosis often present with a fracture. So a fragility fracture is basically an opportunity to diagnose and treat osteoporosis. So the risk of osteoporosis is very high. The fracture risk because of osteoporosis in male is 27% higher than prostate cancer. And osteoporosis account for more days in hospital than other diseases like breast cancer, diabetes, MI, and others. But the awareness regarding osteoporosis is very less. The osteoporosis cycle that a patient with primarily presented with a fracture, if remains undiagnosed and untreated, presents with a second fracture. And this second fracture is basically a preventable fracture. And it has been seen that almost 50% of the trochanteric fractures, they have a previous fracture, previous fragility fracture. So there is a treatment gap, and India is particularly doing very bad in this. 80% of the patients with fragility fractures are not treated for osteoporosis in India. India has the worst death rates because of osteoporosis, and it is almost more than 3 times that of China of USA. And also the disability due to disability adjusted life years is also worst in the world, and it is it is about 3 times that of China. So fracture lesion service is basically a coordinated care model where we guide the patient through osteoporosis care management after fragility fracture to prevent for future fractures. So a patient with a fragility fracture, when he comes, so the basics is the nurse coordinator is there. The nurse coordinator's job is to identify and register the patient into the clinic, and the job of orthopedic surgeon is obviously the fracture care, fracture risk estimation. After we have managed the fracture, we have to estimate the risk of the fracture, future fractures, and for which we need a DEXA scan and a FRAX score. And we orthopedic surgeon also had to start the osteoporosis treatment and do the follow-up. And ancillary support we receive for this clinic from endocrinologist, from physiotherapist, rheumatologist, and dietitian. So DEXA scan is the basis of our evaluation, and it is one of the many risk factors for future fractures. So bone mineral density is not the only risk factor. So the WHO has defined osteoporosis as less than minus 2.5 standard deviation of T-score. So, but from recent studies or recent consensus is to consider many clinical risk factors also while deciding for the future risk of fractures. So in DEXA scan report, you will find many figures, but we are concerned of the neck, BMD, and T scores. And also we should mind if the baseline or the for T score calculation is from white females, the NHA NES data, and also the machine which was used for calculation of the T score is also very important. So for fracture risk estimation, as I said, BMD is one of the factors, and other clinical risk factors are also there, which helps us to estimate the fracture risk. So this can be done by FRAX score. It is widely accepted and is also approved by the WHO. And while calculation, it is a free tool available online. While calculation, we have to enter the country from which we are estimating the fracture risk, and we have to enter various clinical factors which are associated with risk of future fractures, like previous fracture, parent hip fracture, smoking, steroid, rheumatoid arthritis, secondary osteoporosis. So apart from FRAX score, the clinical risk factors which are there in FRAX score, other clinical risk factors are also there, which we need to consider while estimating the fracture risk. It includes recent fracture. For example, in this patient, when we adjusted the FRAX score, for a recent hip fracture, the probability of major osteoporotic fracture doubles, and hip fracture increased more than 3 times. Diabetes mellitus is one more factor which increases the fracture risk, and we can adjust the fracture risk by using FRAX plus. Likewise, hip axis length is there. More the length, more the chances of the fracture, and we can use FRAX plus to adjust our fracture probability by using this technique. Hologic machine is directly give you the reading of hip axis length using its software. Trabecular bone score is the texture analysis of the DXA of the spine, and worse the score, more the chances of fracture, and again we can enter the data in Frax Plus, and it will adjust the score, fracture probability score for us. The number of falls, if the patient is having more than 2 falls last year, the probability of having one more fracture increases by 30%. Again, at times we find patients where the T-score is less for spine and more for the neck. These patients are again have more chances of having future fractures, and the major osteoporotic fracture has to be inflated by the formula given here. Number of prior fractures, primary hypertension are also increase the fracture risk. So after we have calculated the probability, 10-year probability of a major osteoporotic fracture or hip fracture, we can enter it into a website, NOGG website, and along with some basic input, and it will calculate the risk, classify the patient for us, and give us a plot where the patient lies. So like this patient, it lies in the high risk group of 10-year probability of major osteoporotic fracture, and a low risk group in as far as neck fracture is concerned or hip fracture is concerned. So after the patient, we have classified the patient, like when we have started with identifying a patient with a fragility fracture, and we have assessed the fracture risk and classified it as a high risk or a very high risk, then we go for a life expectancy. So life expectancy of the patient can be calculated by CCI, Charlson's Comorbidity Index, and at the end it will give us an estimate of a 10-year survival. So suppose the patient 10-year survival chances are less than 10%. In this patient, it has been shown that initiating an anti-osteoporotic pharmacological treatment further worsens the condition of the patient. So such patient, there is no need to start any anti-osteoporotic treatment. So after we have said that the adequate life expectancy is present, then we look for the calcium levels. If the calcium levels are high, these patients need metabolic workup, and we should not start anti-osteoporotic treatment in them, and we should refer them to an endocrinology specialist for the same. If the calcium levels are low, then also we should not start the anti-osteoporotic treatment and supplement these patients with vitamin D and calcium. And once it becomes normocalcemic, then we have to reassess the fracture risk if the patient need any further treatment or not. So when we have calculated that the calcium levels are normal, and then we have to look for the creatine clearance. So creatine clearance can be calculated online by free tool, where we have to put the gender, age, and creatine levels, and it will give us a creatine clearance estimate. If creatine clearance is more than 35 ml per minute, then we treat the patient with bisphosphonates or teriparatide. If it is less than 35 ml per minute, then we have the options of denosumab. So non-pharmacological treatment include balanced diet, strength and balance exercise, home safety measures like proper illumination or providing anti-slip railings, or to ask them to quit smoking and limit their alcohol intake, and to promote impacted aerobic exercises. So these non-pharmacological treatment are to be advised for all. The most common drug which we prescribe is bisphosphonates. These are anti-resorptive drug and inhibit osteoclastic bone resorption. The oral bisphosphonate usually is the first choice for upper limb fractures. And for the hip fracture, what we usually prescribe is IV zoledronic acid. So there are multiple contraindications, like hypocalcemia is a contraindication. Hypersensitivity is a common contraindication. Pregnancy or lactation, abnormality of the esophagus like achalsecardia or a stricture in the esophagus is one more contraindication. Inability or stand or sit upright are also contraindication. So duration of the treatment, for IV treatment, we require it for 3 to 6 years. And for oral treatment, we require it to 5 to 10 years. So after a fragility fracture, once the patient has started sitting upright, we can start the oral treatment. But for IV treatment, we have to wait for the wound healing. Once you have removed the stitches, you can start the IV zoledronic acid. So there are multiple side effects, like upper GI symptoms is common. That is why we have to ask the patient to sit upright for at least 30 minutes after taking the tablet. Bowel disturbance is also common. Headache and osteonecrosis of jaw and atypical femur fractures are very rare side effects. Teriparatide, it is another one more common drug which we use for treatment of osteoporosis. It is basically a recombinant parathyroid hormone, and it is available in a cartridge form, and which can be injected subcutaneously. Daily injections are to be taken, 20 international unit with this pen. The patient himself can take it. The use of teriparatide is limited to 24 months. And in the lifetime, the patient can take teriparatide only for 24 months. Beyond that, it is not approved. There are studies which shown that any animal studies which have shown association with bone tumors. So it is the first line treatment option when the fracture risk is very high. So when you have classified your patient as having a very high risk of fracture, the teriparatide is considered the first line of the drug. Also, second line option is who are intolerant to bisphosphonates. Suppose the patient is having hypersensitivity, or patient is not able to sit, or there is a stricture in the esophagus. In those patients, again, we can use teriparatide. So teriparatide is contraindicated in hyperparathyroidism. So at times hyperparathyroidism may have normocalcemia. So it has been advised that the patient, before starting teriparatide, you should always have a parathyroid level measured before starting the teriparatide treatment. Malignant tumor or radiation to the skeleton is also one of the contraindication. Pregnancy or lactation is one more contraindication. In side effect, patient may have headache, nausea, dizziness, postural hypotension, and leg pain. One more difficulty with teriparatide is as soon as you stop the treatment, the fracture risk come back to the same level. So it is advised to replace it with bisphosphonates once you have stopped the treatment with teriparatide. So denosumab is the common drug which we use for osteoporosis. It is anti-resorptive drug, and it is basically an antibody against the rank ligand, and it is available in subcutaneous injections to be given in every 6 months. The side effects include skin infection, cellulitis at times can occur, eczema, hypocalcemia, and flatulence are other side effects. Increased vertebral fracture risk after the therapy completion. So there is an increased risk of vertebral fracture with denosumab. So before starting denosumab, we must counsel the patient that patients should not stop the treatment themselves. So they have to come back to the hospital, and then we have to replace the treatment with bisphosphonates for at least 6 months of the stopping of the therapy to prevent this increased risk of vertebral fracture. So we should encourage all patients to maintain good oral hygiene and report unexplained thigh pain, because osteonecrosis of jaw and atypical femoral fractures are again more common in these patients. We having in with denosumab also. Hormonal replacement therapy is advised for patients which are younger postmenopausal women, that is less than 60 years. Other drugs are also available and are advised in patients who are intolerant to these commonly advised drugs. So this is the data of our FLS clinic. You can see that older females about more than 70 years of age are the most common patients. Neck of femur fracture and trochanteric fracture are the most common fracture patterns which are seen in our patients. And there are certain patients which present with fragility fracture but has a normal BMD. You can see more than 10% of the patient have normal BMD. So in these patients also we have to calculate frac score, and if clinical risk factors are there, we have to prescribe anti-osteoporotic treatment. So what is the way forward? That India is performing really bad in it. So we have to perform national policies. We have like National Osteoporosis Foundation. We have to form our own bodies. We have to promote research in osteoporosis, and we have to we have to make more fracture lesion service. You can see in Europe, almost every place there is a fracture lesion service, but in India, only 2 fracture lesion services are there. Our fracture lesion service is not yet registered. So we should increase capacity building by opening more fracture lesion service in our hospitals. So with this, I conclude my talk. Thank you. With this also, we come to an end to this webinar session. I would like to request Dr. Vishnu sir to kindly say a few words at the end of this webinar.
Thank you, Dr. Gunjar. But I have one question. You said that if the life expectancy is less, you don't want for anti-resorptive therapy. May I know the reason behind that?
Sir, because the patient is already having the comorbidity is so high, the patient is already taking many medications. So, and also the most of the times the patient will have limited mobility, and will be most of the times can be a bedridden patient also. In these patients, if you start anti-osteoporotic drug, then it has been shown that it deteriorates the mortality of the patients. So
just giving a denosumab, and that too in one injection, and you know that it doesn't also depends upon the renal clearance, nothing. So I don't find any reason behind why we will not give. Is there
Sir,
any really sufficient data on that that we should not give?
yes, sir. These guidelines are by NOGG guidelines, which are widely accepted and approved by WHO. So according to those guidelines only, the patients with less than 10% survival in like next 10 years, the treatment, anti-osteoporotic treatment are avoided.
Okay, thank you. So if there are any other questions from any panelist or inputs on this,
Thank you, Dr. Gunjan, for an excellent presentation. We've been knowing osteoporosis and the drugs, but we really did not know the sequencing. So I think that's a good idea. Do you really use that Frax Plus for every of your patient?
Yes, sir. We use FRAX scoring of our patients. Though our trauma center is different. We get very few patient of trauma, but those patients we get in trauma, we register them in FLS and we do follow the protocol. What we are having.
Good. Thank you very much.
Thank you, sir.
so with that, we come to the end of this webinar. So we planned for 1.5 hours, but I think we've gone much beyond that because everybody were keen speaking and also the delegates were keen listening to it. So with that, I thank each one of you, all the delegates who were there over the whole period of time and others, and the faculties, Rastogi sir, Samat Mittal sir, Azad sir, Kapil sir, Sip Kumar sir, along with my local faculties, Sumanyu, Dr. Gunjar, Dr. Deepak, and most important, Dr. Deepak Guge, who is a senior resident, who is the person behind all these coordinations. So I thank you very much from Department of Orthopedics, AIIMS Bhubaneswar, for your valuable time and inputs. And I request you to join us and cooperate like in future webinars. Please share your inputs and join us because I know that's a value time and it's a family time Sunday, but still you have spared your valuable time. But still it adds to the value of the residents, and your inputs will definitely change at least few surgeons to change their practice. So with this, I can say that your family time has a worth for few residents. So thank you very much, each one of you. And as said, the certificate, if required, you can scan it. And thank you very much. With that, we come to the end of this webinar. And Dr. Gunjar, I think we can sign out. Thank
Yes,
you
sir.
very much.
Thank you, sir. Thank you,
Okay.
everyone.
Thank you, sir.
Thank you.
Thank you.